Hello and welcome to this lecture. Today we're going to be discussing hypothyroidism. Now today's lecture is going to be more of a clinical application. There's definitely going to be things that are high yield for board review, but it's definitely going to be helpful for those of you in practice right now. So let's get into today's topic. We're talking hypothyroidism. Now, hypothyroid is an endocrine disease, right? And ultimately what happens is this results in a deficiency of thyroid hormone. Now, we can really categorize hypothyroidism into a few different categories. We have primary, we have secondary, and we have tertiary hypothyroidism. Now, let's start off with primary hyperthyroid. All right, so the thyroid gland, right? The primary type is when the thyroid gland isn't functioning. And this is really going to be the most common type of hypothyroidism. Secondary hypothyroidism is when we have a pituitary problem, right? The pituitary gland isn't secreting enough TSH, thyrotropin secreting hormone. And this is going to result in an underproduction of thyroid hormone. We have T3 and T4. And then finally, we have tertiary. This is when the hypothalamus doesn't secrete enough TRH. This is thyrotropin releasing hormone. And if we don't have enough TRH, then this is going to result in underproduction of TSH and ultimately an underproduction of thyroid hormone. And thyroid hormone is going to be T4 and T3. Now, central hypothyroidism is going to encompass both secondary and tertiary causes. And in all honesty, in clinical practice, it's going to be very, very difficult to differentiate between secondary and tertiary. However, it's going to be a little bit tricky. However, it's important that we can distinguish between primary and those that are secondary and tertiary causes as a whole, I should say. So why is that? Because the management is going to differ. Central hypothyroidism is going to be managed a little bit differently, and we'll discuss this in the treatment section. Now, the most common cause worldwide is going to be iodine deficiency. However, we don't have that problem here in the United States, and therefore the most common etiology in the US is going to be autoimmune dysfunction. This is also termed Hashimoto's disease. So overall, worldwide, we're looking at iodine deficiency. In the United States, we're looking at Hashimoto's disease. Now, some quick stats for you. Congenital hypothyroidism is going to affect 1 out of every 4,000 newborns. Now, this is going to be due to a maldevelopment of the thyroid gland. And cretinism is a severe hypothyroid that occurs in the infant, usually from either the mother is suffering from iodine deficiency, all right? So cretinism, severe hypothyroidism, secondary to the mother having iodine deficiency. So as you can imagine, this is far more common outside of the United States. Now, and it's really thought that about 4% of the entire population will suffer from hypothyroid. And it's definitely going to be a lot more common in women, up to 8 times higher. And this is really going to be true for a lot of autoimmune diseases, right? Autoimmune diseases, for the most part, are going to be a lot more common in the female population. Now, the risk of developing hypothyroidism is going to increase with age. And it's found that up to 6% of women over 60 have a TSH over 10. And this is considered to be normal that TSH rise, right? TSH levels naturally increase with age, which then is going to bring us to a predicament when we start doing TSH testing in the older population. Because the standard, right, of TSH of 4 or 5 might be normal for a 20, 30-year-old. However, a TSH of 6 or 7 might be normal in those over 60. But we'll discuss that and we'll get into a little bit more detail further down the lecture. So let's quickly discuss kind of the way this happens, right? How do we actually have production of thyroid hormone? So the first thing we have to know is the thyroid gland produces mostly T4. The thyroid gland produces T4 and small amounts of T3. T4 is considered a prohormone, and eventually this will get converted to T3. Now, T3 is considered to be the active hormone, and T4 to T3 conversion happens in peripheral tissues by 5-deiodination. So very important. Thyroid gland secretes more T4 than T3. However, it's T3 that's going to be the active form. So let's start this off with the hypothalamic pituitary thyroid axis, right? And this is the classic feedback loop that we're always taught in school. So what exactly happens? Well, we have this feedback loop, right? And it's going to stimulate thyroid production and or it's going to stop thyroid production. So starting off from the very top, we have TRH, right? TRH stimulates the release of TSH. So the hypothalamus secretes TRH to stimulate the pituitary gland to release TSH. This is going to stimulate the thyroid gland to release T4. When we have enough T4 produced, then we have a negative feedback loop, and this signals the hypothalamus to decrease TRH production. If we have less TRH, we have less TSH. If we have less TSH, we have a decrease in T4 production. So this is the way the body remains in constant homeostasis. This is the way that the feedback loop works. If we have enough hormone, the body then signals the hypothalamus and the pituitary gland to shut it off. If we need more hormone, the body then signals the hypothalamus and the pituitary to increase TRH and TSH production. Now we said, remember, Hashimoto's in the United States is the most common etiology of hypothyroidism. Overall, across the world, we're talking of iodine deficiency. Now, what happens in Hashimoto's disease, right? The body is going to feel as if the thyroid antigens are foreign. And then we have lymphocytic infiltration of the thyroid gland. This is going to result in destruction of the thyroid gland. Now, most patients are going to have anti-thyroid peroxidase antibodies. So in essence, the body attacks itself. The body attacks the thyroid gland. It feels like it shouldn't be there. And we have destruction of the thyroid gland. If we have destruction of the thyroid gland, then it can't produce T4 and it can't produce T3. Now, up to 10% of women are going to develop what's called postpartum hypothyroidism. And it can happen up to 1 year after conception. And this is typically going to resolve after a few months. Next, we have what's called subacute thyroiditis. Now, this is rare, right? And it's a rare presentation that occurs in middle-aged women who are going to be presenting with thyroid pain. So when you palpate the thyroid gland, it's going to be very tender. Patients can also present with a low-grade fever, dysphagia, and we're going to have an elevated ESR. Now, it's thought that this is viral in nature and it's self-limiting 1 to 6 months, so you don't necessarily need to do much about it. We can give some pain medication, and again, we'll discuss this more in the treatment. So for this type of thyroid disease, right, for this type of subacute thyroiditis, we're looking at middle-aged woman, painful thyroid, low-grade fever, dysphagia, elevated ESR. It's going to self-resolve after 1 to 6 months. Then we have something called drug-induced hypothyroid. Drug-induced hypothyroidism can definitely occur, and this is secondary to medications. So medications that we're going to be to look out for are going to be tyrosine kinase inhibitors, and these medications per se are used to treat many types of cancers. Amiodarone is a big one, lithium, rifampin, phenytoin, carbamazepine, and phenobarbital. These are all medications that can induce hypothyroidism. Now, we can also have hypothyroidism secondary to neck radiation following the treatment of head and neck cancers, right? This can also be secondary to breast cancers and Hodgkin lymphoma treatment. So these are medication/radiation-induced hypothyroidism. This can definitely happen as well. Central hypothyroidism, right? We said this was a very important cause, something that we had to look out for because the management is going to be slightly different. So central hypothyroidism really occurs from pituitary tumors that are impinging on the hypothalamus, trauma. We can have Sheehan syndrome. Now, Sheehan syndrome is going to be a postpartum pituitary necrosis. Postpartum pituitary necrosis, Sheehan syndrome, can cause central hypothyroidism. Drugs can also do this. So dopamine and corticosteroids are going to decrease TSH production. Dopamine, corticosteroids decrease TSH productions. And finally, we can have TRH deficiency and or resistance. And this is going to be a mutation of a gene, right? TRHR gene. So these are the various different types. But like we said, the most common cause, Hashimoto's disease, autoimmune destruction of the thyroid gland. All right, so let's get into some clinical features here. Now, we're really going to have two different things that are going to be occurring. We're going to have slowing of metabolic processes, and we're going to have accumulation of these long-branched polysaccharides. So let's start off with the metabolic changes that occur in hypothyroidism. We all know that people get lethargic, we have fatigue, We have slow movements, slow speech. We have the classic cold intolerance that occurs, constipation. We have weight gain, but it's very important to remember that hypothyroidism does not cause morbid obesity. You have weight gain, but you do not have morbid obesity. Now, a big one here as far as the physical exam goes is we're going to have delayed relaxation of the deep tendon reflexes. This is the relaxation phase. So if you tap the knee comes up normal, and it's going to have a delayed relaxation phase. This is going to be seen in hypothyroidism. We can also see bradycardia. This is going to be slowing of the metabolic processes, right? Everything just kind of slows down. Fatigue, slow movement, slow speech, constipation, weight gain, delayed relaxations, bradycardia. These are going to be the metabolic changes. Now, what happens when we have these accumulation of these polysaccharides that we discussed, right? This is when we're going to get these other features. This is when we get coarse hair, we get coarse skin, thick skin, we get puffy faces, we get non-pitting edema, and we get enlargement of the tongue, right? And when we have enlargement of the tongue, remember, this can predispose the patient to sleep apnea. So we have coarse hair, skin, puffy faces, edema. We can have a sleep apnea secondary to enlargement of the tongue and hoarseness. So these are the different various features that can occur with hypothyroidism. Now, patients are going to have a decreased cardiac output that can cause dyspnea on exertion. We might also see hypertension, right? Because we have increased vascular resistance. We can have hypercholesterolemia because of the decreased rate of metabolism. Now, women are often going to have a menstrual cycle that's going to be kind of disrupted here, right? And we can have various different presentations as far as the menstruation goes. We can have oligomenorrhea, we can have amenorrhea, we can have hypermenorrhea, menorrhagia. So it can really present in different ways. There's no one way. Classically, we're thinking of amenorrhea, right? Where the patient doesn't have a period whatsoever. But it can definitely cause hypermenorrhea, menorrhagia. So just know that if we have an abnormal menstruation, abnormal menses, this can definitely be a sign of hypothyroidism. And because of this, there's going to be a decreased risk of fertility, and there's going to be an increased risk of having abortion. Now, this is also going to be a cause of having hyperprolactinemia. And oftentimes, if we correct the hypothyroid, the hyperprolactinemia is going to resolve as well. Now, what about the males, right? Obviously, males are not going to have any type of menstrual features, but males can definitely be affected as well. They can have decreased libido, erectile dysfunction, and delayed ejaculation. Carpal tunnel is often going to be associated with this as well. Carpal tunnel syndrome is going to be very common, seen in up to 35% of patients. Now, typically, we're looking at bilateral carpal tunnel syndrome. When we're talking hypothyroid, if you see bilateral, we have to think, does this patient have other features of hypothyroidism? We can have sensory loss in the feet. We can have the stocking glove pattern, also very common. And remember, we can have the delayed, relaxed, deep tendon reflexes as well. Muscle weakness, myalgias, cramps, joint pain. These are all very non-specific features that can be seen in hypothyroidism. So, just very quickly regarding the physical exam, the clinical features, the ROS. They're very non-specific complaints. There's no one thing that is going to point you in the direction of hypothyroidism. It's kind of a constellation of symptoms. The weight gain, the fatigue, the joint pain, irregular menstrual cycle, prolactinemia, if you're a male, delayed ejection, erectile dysfunction, decreased libido. Very non-specific, but if you start to have 2, 3, 4 different symptoms, you kind of have to start wondering, does this patient suffer from hypothyroidism? So let's say you suspect hypothyroidism, right? Let's get into a little bit of the clinical features that are going to be seen on laboratory testing. Now, patients are going to have hypocoagulable states. This means they have increased risk of bleeding. Patients are also going to have a decrease in the red blood cell production. This might lead to a normocytic, normochromic anemia. And about 10% are going to have pernicious anemia, which is going to present with a macrocytic anemia. 10% might have pernicious anemia. Pernicious anemia is an autoimmune disease. Hypothyroid caused by Hashimoto's is an autoimmune disease. autoimmune diseases often go in groups. If you have one autoimmune disease, you're at risk for having a second. Hyponatremia can also be noted because we have a reduction in free water clearance. This is going to cause elevated levels of creatinine, elevated levels of homocysteine. However, these are often going to return back to normal, back to baseline, once we give the proper treatment. Now, in primary hypothyroidism, this stimulates, right? Primary hypothyroidism stimulates increased TRH production, which can lead to hyperprolactinemia. Now, usually the prolactin level is going to be under 150. And like we said, once we correct the thyroid dysfunction, the prolactin levels return to normal. So these are laboratory features that might be seen in hypothyroidism. Now, how do we actually diagnose hypothyroidism? So this isn't necessarily going to be a clinical diagnosis. We said a lot of the symptoms that are presented here are going to be very, very non-specific, right? So we need laboratory testing. And really the crux of diagnosing this is going to be with TSH and free T4. So we have two lab values we have to know. TSH and free T4. Not T3, not total T4. It's very important not to order T3 because early on in the disease process, there's going to be an increased conversion from T4 to T3 in an attempt to maintain normal T3 levels. This is a compensatory mechanism that happens within the body, right? So we have an increased conversion T4 to T3. So if you measure T3 levels, initially they're going to be normal, but the T4 levels are going to start to decrease because we have this increased conversion. And again, we're not measuring total T4 levels. When we measure T4, right, total T4 I should say, total T4 measures the amount of T4 that's bound to thyroid binding globulin. This is TBG, thyroid binding globulin, transthyretin, and thyroid binding prealbumin and or to albumin. So essentially total T4 is T4 that's bound to another protein. And these proteins are definitely going to vary depending on a ton of different factors, such as the hormonal status of the patient, inheritance, and comorbidities. So this is why we're always getting free T4. We're getting the unbound T4. So again, the test of choice is TSH and free T4. Now, when we have primary hypothyroidism, we're going to have a high TSH and a low free T4. Primary hypothyroidism, problem with the thyroid gland, high TSH, low free T4. Now, central hypothyroidism is a little bit tricky. Why? Because we're going to have inappropriately elevated TSH, right? This means that it can either be low or it can be low normal. And we're going to have a low free T4. So if we're only screening with TSH, we might miss central hypothyroidism because it can fall within the normal levels. It's going to be low normal. And then when we get the free T4, that's going to be low. Remember the negative feedback loop. If we have a low free T4, this should trigger an elevated TSH. If it's not elevated, we might have what's called central hypothyroidism. And subclinical hypothyroidism occurs when we have an elevated TSH, but we have a normal free T4 level. So the body's feedback loop is maintaining the normal free T4 levels by increasing TSH production. All right, now 95% of all hypothyroidism cases are going to be primary hypothyroid. Problem with the gland, 95% elevated TSH, decreased free T4. Therefore, the first test should always be a TSH. Right? So if a patient comes in with fatigue, for example, with decreased libido, menstrual irregularities, some weight gain over the last year, then we're getting a TSH. If the TSH is elevated, the next step here is to then get a free T4 and then couple the TSH again. So we're getting two levels of TSH to confirm, and then we're getting the free T4. But remember, we have to be careful because in central hypothyroidism, the patient can present with a normal TSH. So if you really suspect the patient has central hypothyroidism, but you have an initially normal TSH, you're going to repeat the TSH and you're going to get a free T4 measurement. So what are some things that might clue you in to central hypothyroidism? Well, if the patient already has known hypothalamic disease, probably has it. If we have pituitary disease, there's probably justification. If we have a mass lesion present in the pituitary gland, and or if we have symptoms and signs that are associated with other hormonal deficiencies, we have to think that the patient might be suffering from central hypothyroidism. Remember, the problem here is that we have either decreased TRH or TSH production, depending if we have hypothalamic disease and or pituitary disease, right? So we have a decreased production of TRH, decreased production of TSH. The body is unable to increase TSH levels in order to compensate for these decreased T4 levels, right? A couple of other presentations, a couple of other ways this might present. We have a free T4 that may be low normal with a low normal TSH, right? So the TSH may occasionally be slightly elevated because we have biologically inactive secretion of TSH. So the diagnosis of central hypothyroidism might be a little bit tricky in some patients. Now, when we're talking about antibody testing, Hashimoto's disease, we said primary hypothyroidism, more than 90% of these patients with Hashimoto's are going to be positive for antibodies, thyroid peroxidase antibodies. But do we really need to get them? Probably not, right? Routine measurements of these antibodies are really not going to be needed, but they're probably going to be present in about 90% of patients. And the thing is, you're not always going to have patients who come in with symptoms, right? And or they might not want to discuss symptoms such as weight gain, such as not having a menstrual cycle, and this happens very, very common as well. So some of these cases are going to be diagnosed on routine screening. Now here comes the controversial problem here. Who really needs to be screened for hypothyroidism? So who needs to be screened? Well, patients who are at increased risk. These are going to include patients with a goiter. They have a history of other autoimmune diseases. If they've had previous radiation or iodine therapy, a family history of thyroid disease, and use of medications that might alter thyroid function. And we discussed these medications earlier on in this lecture. The problem is there's no real data that supports routine universal screening. And there's the universal screening during the first trimester of pregnancy is also something that's very, very controversial. There's no agreed upon consensus. Typically, you don't screen during the clinic in the first trimester. Our clinic doesn't routinely screen, but we are going to order a TSH in those patients who are at high risk and or patients who present with symptoms. The problem is a lot of patients who are pregnant are going to have symptoms that are very, very similar to hypothyroidism. The problem is that the beta and alpha subunits of the TSH are going to be very, very similar to HCG, which are going to alter the thyroid levels. And this is a topic that deserves its own lecture, so we're not necessarily going to get into that. Like we said, other medications that might impair thyroid, right, or that might impair the TSH are going to be things like dopamine, glucocorticoids, octreotide can do it, metoclopramide can do it, amiodarone can do it. So these patients might be increased risk, and therefore screening might be beneficial for these patients. Now, patients who have an abnormal TSH should not get an ultrasound of the thyroid gland. It adds nothing to the diagnosis. Abnormal levels of thyroid, of TSH, free T4, these patients do not need a routine screening for ultrasound. It's only useful if your physical exam uncovers a possible nodule. Then get the ultrasound. Otherwise, do not order this routinely. Now, when we're talking about subclinical hypothyroidism, it's really estimated that up to 50% of patients who are diagnosed with subclinical are going to progress over to hypothyroidism. So those who have TSH values that are over 15 and those patients who present with antibodies are definitely going to be at increased risk. But the bigger question is, who needs treatment, right? What level of TSH warrants treatment? And as we said, those who have higher levels of TSH are going to be at increased risk of developing hypothyroidism. And this is why we advise patients who have a TSH over 10 to start treatment. Now, it's not really clear what to do with the patients who have a TSH of less than 10. And really the consensus here is to treat if the patient has any type of hypothyroid-like symptoms. Now, there are many studies that are going to show conflicting evidence. Some are going to show improvement of symptoms. For example, they have a TSH of 8. They come in with fatigue. Some clinicians might give levothyroxine. Some studies have shown that this gives improvement of symptoms. Other studies don't. So it's really at your discretion. The consensus, however, is not to treat if the patient has no symptoms unless they have a TSH over 10. Now, there are some experts that are going to argue that the asymptomatic patient who has a TSH under 10 should also be treated because of unrecognized symptoms that may improve once we correct the TSH levels with levothyroxine, right? Now, another thing that might improve as well are going to be abnormal serum lipid concentrations. So if we have abnormal lipid levels, this may improve as well, and this may be cardioprotective. And there's really going to be a very, very little risk of actually giving T4. So very, very little adverse reaction potentials. So if the patient has other risk factors where lipids are going to play a big role, like the LDL, if you have diabetes, hypertension, then correcting TSH may be wise in order to correct the lipid levels. Again, this is going to be based on individual patients. This is going to be based on your clinical experience, what you're comfortable with, what you're not, because this is not universally accepted here, right? Now, what about the patient who has a goiter? So patients who have a goiter and are given levothyroxine treatment are going to be shown to have reduced size of goiter. So this is definitely going to be an indication to treat. And those with very, very high antibody levels are also candidates when the TSH is less than 10. Now, women who have TSH over the trimester specific, remember, the TSH subunit is going to be very similar to HCG. So we're going to have trimester specific levels that are not going to be the same as those in the normal population. So women who are over the trimester specific value should also be treated. And women who want to get pregnant but are having difficulty are also candidates for treatment if the TSH is less than 10. All right, so this concludes today's lecture. We discussed a lot of information here. We went very in depth with hypothyroidism. Now we're going to split this up into 2 lectures. The next lecture is going to be released on Friday, and this is going to be the treatment of hypothyroidism. So stay tuned for next week where we discuss part 2, treatment of hypothyroidism. Thank you guys so much for watching. I appreciate you, and I'll see you in a few days. Take care. Bye.